Testing 1 1, testing 1 1. Test 3 4, test 3 4.
think like you sit in the wrong end. You sit on the wrong side, sir. No, I'm just getting so used to having you on this side.
I have.
I'm assuming everybody's over here is on the right, and you may be need to be on the left.
Are you saying on the wrong side?
I think. Welcome to our Finance and Planning Committee meeting. We have a quorum, so we're going to get started. I don't recall receiving any, so we don't have any citizen wish to address to the committee. So we're going to move to the next item, which is the approval of the minutes. I hope everybody have a chance to take a look at it, and any comment, any edit, suggestion. If not, may I have a motion for approval.
So moved. Second.
All in favor? Indicate aye. Any opposed? Motion pass. The next item, at this point, I'm going to turn the agenda over to our other chair.
I don't think I have anything.
We don't have anything, sir?
We have no planning items for today.
Wow.
I think that we're going so well. In planning and things like that. The board. We're getting our job done.
Yes. I'm assuming we have a great chair, a great chairman of the board, and a great CEO and a CFO.
Sounds like you need more oversight.
Welcome, Reverend. And we're going to continue with the Finance Committee, and welcome our CFO, Shannon.
Hi, good morning. A couple of updates. We are approaching the summer, which means everything collides in finance. We have our auditors that will be out for interim work soon in July. BKD serves as our external auditors. We have also budgets that are really starting to pick up. From your perspective, in the July board meeting, I will kind of recover and update the projected 23, where we feel like we're going to end up our year, which will hopefully prepare and get you up to date for our 2 budget strategy discussions at the end of July. The first one is going to be more around strategy again. The second one will be more about what you will see at the August board meeting when we are asking for your approval for our 24 operational budget. So just so you kind of know the importance of the meetings and the cadence, if you have any questions or you don't think you're going to make those meetings, I'll be happy to meet with you individually on those.
What are the dates on those meetings, Sharon? August 4th is the second one, right?
July 21st and the 28th. Those are Friday afternoon. And then August 10th is our scheduled board meeting.
Okay, thank you.
You bet.
Just for transparency, if board member wants any detailed information, asking question, please contact her, but copy me and maybe our CFO so that we're aware of things changing so that we keep track of it also as well. But you're welcome to ask a direct question. Yes, question, sir? Oh, you're not the only one. That's why Zim moved closer. No, just as a matter of, to keep everybody in the loop, because the schedule is moving pretty rapidly, especially around finance and budgeting and all that stuff. So if you have questions, direct them to our CFO, but at least copy me or the CFO so that we can be aware, so that we can keep things moving. Otherwise, too many direction and stuff like that to keep track of.
So if we're not going to be there, because I can't be there the 28th, we copy you on needing to sit down with Sharon independently? Is that what you're saying?
Just questions so that we can all be on the same page.
Okay.
Because we normally don't have that problem, but we have new members, so we just want to make sure that we coordinate the activity correctly.
Okay.
Okay. If there are no other questions, I'm going to move on to the April financials. So So from an inpatient standpoint, we were right on budget for April for admissions. You can see that our CMI is just below budget. That was to be expected as we continue to evaluate documentation for inpatient status versus observation. Our length of stay has been up for the last few months. If you look back, there are 2 to 4 specific patients that have longer lengths of stay in excess of 250 days that were discharged. And length of stay is calculated on those patients that are discharged that month. So that is the reason for that uptick in the last quarter.
Do you
From
know
it-
what type of insurance they have? Are they JPS or they Medicare type patient?
This last month, they were 3 separate insurance categories, and their diagnosis was across the board. So there's not like a specific patient type that will typically hit. They're obviously very intense patients.
So these are outlier type thing.
They are, yes. So, but if it happens 3 months in a row, is that still an outlier? But there are not that many patients in the hospital that are long-term, but we do have them. And periodically, we have kind of a group discharged, which was what was skewing April.
Just for other members to be aware, I've raised this question during our review of the agenda, and because I want to make sure that our population hasn't changed or coding. There's a lot of initiative with consultant coming in to help us with the coding and all that stuff. And I want to make sure that we don't undercode while the hospital state the severity is higher or we got paid by the DRG type thing. So, but it's for another discussion. Want to give them time to review the data and all that stuff, and then if anything jumps out, we'll come back and report it back to us. Okay, thank you.
Outpatient, the emergency department continues to have an uptick. Anecdotally, I think this is driven by our ability to manage some throughput. Our left without being seen rate last month was 2.3%, which is incredibly low. 6%, I think, would be statistically a win from an industry standard standpoint. So we're doing really well there. You can see that urgent care continues to trend just above budget, and primary and specialty care visits were under budget, but they were right on with prior year. Surgeries continue to be over budget, both in inpatient and outpatient. We have made some changes earlier in the year, opening up OR schedules and making sure that all rooms were staffed. We worked with anesthesia, and you can see that we've really been able to sustain the higher volumes in surgery.
How's the severity of the inpatient surgery?
I haven't looked at that, DT. I'd hate to take a guess on that. I know that we've gotten a couple of new surgeons this year. I think one was in neurosurgery, as well as in orthopedics, and those tend to be a bit higher acuity from an inpatient standpoint.
Maybe Dr. K can help us later on to look down the road, because I think my question is more around, because of the pandemic, are these cases coming back up because they haven't seen the doctor during the pandemic, and the disease progression is a lot higher or lower, so that we can see the risk that we have on our JPS population?
Yes, it would be included in all of that.
Yeah.
What I would say, DT, is I don't think we're seeing a higher complexity of surgical cases. I think it's our usual JPS cases, but what I mean by usual JPS cases, our cases are highly complex. We have, historically, I've been here 7.5 years now, and our surgical patients are often oncology patients in high stages. They don't get to care very quickly, and so we do have very complex surgical cases. But I don't think that it's changed pre-COVID to post-COVID, if that answers your question.
Because the CMI is actually lower now, but the length of stay is longer. So it's a lot of stuff that we need to kind of trying to get an understanding around that.
As you know, length of stay is a complex conversation. Multiple factors affect length of stay, and it's not as much the surgical population, but there's also a medical population that's affecting length of stay. But that's a whole nother topic.
Right, but it could be not as could be also discharge or transition care type thing also as well.
Yeah, I think there's Dr. Assad obviously knows this world much better than I, but in speaking to her, the length of stay is significantly impacted by our inability to discharge because we don't have a safe place for patients to go. And so that's a continuing problem based on our demographic.
That's why we're looking at transition care also as well, I think. Thank you.
And our behavioral health service line, it stayed very consistent this year. In patient days, although those look pretty close to budget, we've actually seen an increase in admissions and a lower length of stay. So we're seeing more patients through. So that's a really positive change there. Our clinic continues to be busy and on budget, as well as the emergency, the PEC. Although it's slightly under budget this month, it was equal to March. We've also, because of the throughput with our psychiatric population, we've had much lower outside medical services. So we've been able to accommodate more patients here at JPS and not have to send that overflow to our community partner. What? Again, a real focus on length of stay and discharge planning. We've been able, even though the patient days, again, look very close to budget, we've actually, it's a whole lot more admissions and a lower length of stay. So a lot of attention and great management has really helped that. The bottom left, outside medical services graph, we put that up, gosh, I guess it's been 4 or 5 years ago, because it is a significant outside medical expense, and it's very closely tied to our ability to keep the inpatients here at JPS, as well as the volumes that hit the PEC on a monthly basis. So it's all kind of there together.
Behavioral
It
health
is.
follows this very closely, and they were the last one to really bring down those COVID units because they do have a lot of group admissions, and so once they were able to bring those down completely and utilize those rooms, but they've always watched this very closely and have been able to
Yes.
bring savings.
Yes. We're about 40% lower on average than last year. From the acclaimed providers, the CPT codes, it's kind of trending a little bit with the outpatient visits. The CPT codes are a lot more than the primary and specialty clinics, but that is a large volume of what they do. And then you can kind of see their payer mix has remained pretty constant throughout the period.
Karen, and you may be going to address this, we've got kind of a sustained net operating expense per CPT over what we've seen in the past and over budget? What's causing that?
I think that a little bit lower volume and then the implementation this year of the new comp plan. We anticipated certain, and when I say lower volumes, that's not across the board. The surgery is much higher on their CPT, a lot of the specialties, any procedurally driven specialty like orthopedics. We've seen a big uptick there, so it's really driven by that comp plan and the salaries. And you're not looking necessarily at the bottom line, you're just really looking at the expenses there. So it's a bit misnomer.
There's a corresponding increase in inpatient surgeries, right?
Yes.
When we see a corresponding increase in surgeries, we're going to see a net expense increase here, right?
Yes,
Okay.
yes. So from an overall budget favorability, it's still positive, but the expenses are driven up a little bit, but the operating
Okay.
revenue is up more.
Okay, thank you.
You bet.
Sharon, question on the acclaimed payer mix. How can April, if you look at commercial, be about 3.45%, I think it says, but for the whole year, it's over 15%. What drives the commercial mix so low for 1 month?
So what I'm thinking is happening there is we are working to try to get more commercial qualified for that. You'll see that start to go up month after month. And I need to check this graph because I think we may have miscategorized one or two plans personally. So I need to double check that and let you know next month. So on the medical center, you can see that the FTEs per adjusted patient day up on the top right is still favorable. We have included in this is the contract labor hours. So this should be a really good focus on paid hours per adjusted patient day, which is kind of an inpatient, outpatient volume combined. But it is still favorable. But when we go to the financials on the next page, you're going to see that our rate has gone up and continues to go up. We've had market increases this year, especially with the patient-focused staffing and nursing and other ancillary areas. So we're doing a good job on hours, but the economics of healthcare continues to drive up that hourly rate. So when you look at the consolidated performance for the month, we finished just under 13 million. There are a couple of things I want to point out for the month. Our net patient revenue was favorable by about 8%. But if you drop down to other operating revenue, which is the fourth line down, you'll see a variance of 1.6 million, and that's where our tobacco revenue is recorded. Each year, the state allocates out of the tobacco trust fund, and we had budgeted 9 million, which is what we received last year, and our allocation this year was 10.6 million. So we did record that. We were notified and have received that money in April. Again, in salaries, we continue to see an overage of salaries and benefits, and included in that is contract labor. We were a bit unfavorable in the flex, but I think that's because our inpatient volumes have dropped a little bit, and we have, again, had to do some market adjustments for some staff, so we're starting to see some of that come through. Year to date, we still are about 5 million favorable on a flexed basis for that additional volume.
Sharon, on that other operating revenue, have we, or do we plan to book any opioid reimbursement money in that same account, and have we seen any yet?
So I think with my conversations from BKD, there's a lot of discussion on how you would book that from a gap or governmental standpoint. I think that will likely end up in the non-operating revenue.
Not operating revenue.
But we would not book or accrue that until we actually receive those funds.
Okay.
I don't know if it will be in this fiscal year, and I would not intend to budget it for next year. It would just be kind of a windfall.
It's a one-year windfall.
I believe that's the way that it will be paid out. There might be a couple of payments or waves typically with government distribution. They have a formula and they send it out, and then there's a couple of non-qualified hospitals and they typically keep a little bit of it. So you might have 2 waves just to clear out the calculation.
Okay.
But I'm not sure when.
It's not going to be like tobacco, though. There's not going to be a multi-year pay.
No, the way that tobacco works in Texas, it's been really interesting. They put all of that money into a trust fund, and there's a committee appointed that invests that fund, and it's pretty complicated. I've been to one of their meetings. I sit on the distribution committee, not the investment committee.
Okay.
So they really have worked to protect and to try to increase that tobacco distribution each year by medical CMI. So that's why you're seeing that increase from 9 to 10.6, despite the performance that we had in investments last year. So the state's done a really good job setting up that committee and the management of that, so you don't have the market fluctuations. They don't distribute it all. They do kind of look at a 5-year average, which has really benefited us.
Yeah. But that's not what they're going to do with opioids.
No, that is just going to be a distribution,
Okay.
to my knowledge.
Okay, thanks.
The last thing I want to point out is down in the very bottom, kind of that interest and financing expense, the 3rd or 4th line from the bottom. We are recording $1.6 million worth of expense against a $2 million budget for the bond issue. The main reason that's favorable is we had budgeted 4.85%. We issued at 4.4%. So that'll be a favorable variance for the rest of the year. Are there any questions on April?
That last paragraph on your sheet, could you explain what portion of operating income you anticipate moving into bond initiative money, or has that calculation been made, or what does that look like?
So that's a great question. What Trent's talking about is the JPS Future Fund. Right now, we have about $612 million in that fund. If you recall, we have to come up with $700 million for the $1.5 billion of construction to take us through the second phase in the building of the new towers. We look at that during the budget process, and historically, I have brought that back to you guys during that August meeting to make a recommendation of what we should move over into additional funds into the JPS Future Fund. So that's my plan. It's not driven by the income statement. I look at how many days cash on hand we have on the balance sheet. I try to target around 225 on average. Remember that our cash fluctuates tremendously during the year. We get good tax revenues in December and January, and then we slowly spend that down until the next tax year. So it's really going to depend on our day's cash. Right now, I think each day costs about $3.5 million.
So
It's a big number.
So, I mean, we're looking, we're looking pretty much at right now, we could actually take, it's based on the income statement, we could actually take the surplus over budget relative to the $700 million, and we could pretty much cover it. But
Yes.
we're going to look at it based on today's operating income and not necessarily based on the income statement.
And what we expect to spend last year,
Okay.
or next year, right? So if there's big initiatives, which we'll be talking about in July, if there's an increase in our
Yeah.
day expense,
I think
we'll
it's
try to
really-
plan for that.
I think it's really important that we keep an optic understanding of that $700 million balance and that need relative to the bond fund. So if there's a way to start categorizing that so we see how we are doing relative to that, because that's money we know we're going to have. And it's almost like a debt service. I mean, we have to have it. So if we could start showing that somehow and classifying that in terms of ongoing balance, a running balance, that would help, I think, see it.
So on the balance sheet, I don't spend a lot of time on our balance sheet typically, but right under that black line, you can see the future fund at $612 million. And then the bond monies from the issuance is at $430 million.
Okay.
We have reimbursed ourselves about $12 million based on that reimbursement resolution we did about a year ago.
Okay.
And if I may, in my mind, the future fund doesn't have to be complete at $700 million. We still have $350 million that would have to be taken care of in a second bond issue.
Right.
And if there's a way that I can prevent a 30-year burden of interest expense of another $1.5 million a month for the next 30 years, if there's an opportunity for me to reduce that $350 million bond issue, I will make that recommendation to you. So,
That's something we're going to want to see
yes,
because that's got two edges on it.
yes,
To the extent that we've got to focus on operating surplus or operating deficits, we know if we load that thing up too much, I would suggest that you encumber the 700 so that we know what that encumbrance category is going to be.
yes.
We continue to show that balance over and above, and then before we make any transfers based on operating expenses, let's see it and let's make sure we
Oh,
understand.
you will see it. The only way to get dollars into that future fund is through a board resolution.
Okay.
That is not, I will make a recommendation to you at the finance committee, and I'll work through that with DT before. But I'm just kind of speaking through my thought process is, the rate environment right now is crazy.
Yeah.
We don't see a decrease in the interest rate as we, in the next, or the foreseeable future, and who knows what's going to happen in the next 3 to 4 years. So if there's a way that I can set JPS up for success financially by not having to issue some really high-cost debt, I'm going to be proposing that.
Good, that makes sense.
Okay.
Thank you.
Sharon,
Yes.
back on the bond program, I think it would behoove all of us if at least not every month, maybe every 2 months or maybe every quarter, to have a dedicated pitch on the bond program by project as well, to kind of show us where we are and so we can keep up to date on the progress.
Okay.
And then secondly, why are we so far over budget versus our revenue, net income?
So if you look back, most of it's driven by our inpatient. So if you look at the admissions, typically most of our contracts will pay us based on at admission and discharge. We are, let's see, I don't have the percentages there, but I do write them here. We are 16% over in admissions for the month. We also have had a favorable change on a large commercial contract. Our Cigna, the Cigna plan that you guys had approved a few months back, at the beginning of the year, we started to see some significant volumes from that contract as well. So it's really driven mainly by that inpatient volume.
I know a lot of businesses do what I call a leveling budget, knowing that full well some months it's going to be way down and then some months it's going to be way up. Would we expect this to start coming back towards the budget as we go through the rest of the year?
I expect the blue bar trend to really be the driver, not where I thought it might be 16 months ago. And as we prepare for the 24 budget, we'll be trying to trend it over the last couple of years and see where we think those inpatient volumes will be going. We also look at recruitment of new specialties and try to take into account any retirements of key physicians, et cetera, as we work through these volumes. And we're doing that currently, trying to get ready for the 24 budget.
Yeah, I think, and Sharon and I've had the same conversation internally. This was a challenging year to set the budget because we were coming out of COVID, so there
I
really
don't want
were.
excuses.
I know, COVID always is, but we really didn't have trends. It was really trying to reset. We did not know what was going to happen and how best to begin to set that. And so we were probably a little bit more conservative, but at the same time, and we weren't sure when people were going to start to come back. I think it's all timing, as Sharon has always said, when we set that budget and then what actually occurs.
Well, a fourth of that is supplemental Medicaid funding, which we didn't know we were going to have. So, I mean, that's a big determinant, and we don't control that.
We don't. I mean, a lot of our budget we don't control. I'm just going to be honest with you. And we work really hard to help cover those costs because, it's never set up that you're covering all of those costs.
Yeah, I was going to say, that's a good problem, but it's a big gap between budget and net income that we're getting. And one more thing, contract labor.
Yes.
Went down. Is this a result of us beginning to come back to normal with our employment?
Yeah, we are seeing, in fact, we've been able to hire from some of that contractor travelers that we were using, some of those who were no longer being asked to go elsewhere, right? And so we were able to recruit a lot of the really good ones that we were able to work with. And so we are seeing, I believe Jill informed me that, I don't know if she's in here, that I think in our ICU, and I think we're getting close in our ED with no contract help. So we are starting to get more permanent staff.
Thank you.
Yes, sir.
Similar question. I think we talked about this last month. I mean, the pharmacy had another great month. Anything particular driving that? Just contracting?
So you're talking about the retail pharmacy line item?
Right.
A lot of that is driven by our outpatient volumes. All of our JPS connection patients will access this retail pharmacy. Remember that that's not just revenue. There's a whole income impact going through there. So on our supply expense overage, a lot of that is pharmacy. So that 81 for the month, for example, for April, doesn't just fall to the bottom line. There's a lot of staffing cost and there's a lot of supply costs that go on with that as well. But it will be a favorable impact to our bottom line from a pharmacy.
Good. And just to make sure I'm reading this right, the taxpayers have given us, not in Medicare, not in Medicaid, but just in direct tax revenue, $332 million year to date?
Correct.
Through
Yes.
April? Okay.
And it's right on budget. The tax office will collect the money, and we get that within a couple of days from collection. And then we continue to accrue it. But all throughout the year, there are appeal adjustments, and so it's never exactly what we budget. But yes, that is what we will accrue to the end of the year.
Sure.
On a monthly basis.
And is the ad valorem tax booked on a cash basis or accrual?
No, it's accrued. So each month, you'll see approximately that $47 million booked.
But we get most of it in December and January.
Correct. Yes. Any other questions? Good discussion today. Okay. Just need approval, Mr. Chair.
And motion for approval?
Oops.
Move for approval of the report.
All in favor? Aye.
Aye.
Any opposed? Motion passed. Thank you, Sharon.
I didn't get the dates for the budget.
21st and the 28th.
It's the what?
21st, July 21.
You know, July 28th, I don't think I'm here.
Okay.
Go back. I don't think I'm here then, okay? Trent, you're not going to be here on the 28th. I'm almost positive.
We have our vice chair doing a dry run. Audition for next year.
Yeah. I'm going to check my schedule to make sure. Okay, let me go back. Yeah, but it's July the 21st, I'm okay.
Or maybe
But
see
it's
if
the
they have the
August.
flexibility about an hour or two.
That's when I'm going.
We can zoom them in or something.
Yeah.
We want to see if they have passion.
Speak up, would you?
Hi, Rory, how are you? Morning.
Good morning.
Go ahead, sir, for item B.
All right, 7B is a contract with a company, Experian Health. We use this technology for address verification and other demographic components of a patient's record. The technology also flags registration errors. And one of the kind of cornerstones of RevCycle is clean claims and accurate patient information. You can see the cost. There's $132,000 roughly annually, and it's also included in the operational budget. We did conduct an RFP with 3 different technology companies, and it was awarded to Experian. Would take any questions and request your approval.
I'm assuming this is, like a better word, this is for skip tracing, right?
You know, if you look at the 3 credit bureaus, TransUnion, Equifax, and Experian, they all have the data to be able to do what you're talking about, which is verify the patient's information that's being provided to us. A lot of us don't think about in terms of us moving very often, but a lot of people do, and so this helps us kind of keep that address and patient information accurate. So skip tracing, it's a different word, but it's really just verification of the address.
Once we verify this, do we ever compare that with the clinical side to see if they have the patient with the right address for, for care management type thing? Because if it's wrong to begin with, how do we get in touch with them if we find a way to correct that? Right?
Yeah, from a standpoint of maybe their primary contact within the clinical side, the record, versus what the business side has? It's a good question. I'd have to see what the primary contact is that they're relying on.
November 29th of 2022. What's the turnaround time on once these contracts are finished and implemented versus what, when we see it, I guess is the right way to put it. Because November of 22 is a long time ago. So how long should we expect these contracts, once executed, to appear on the agenda?
I think normally you would see no more than 30 days. I think there were some things contractually we were working through with them just to get it cleaned up before presentation. I don't remember what the exact issue was, but I can definitely, this is not normal. It shouldn't be.
Yeah, and just to clarify, it's not executed before it's fully approved.
But
So-
they have executed it, we haven't executed it, which is a long gap between November and now.
Correct. And so there's the negotiations part that probably is not seen before you see it.
So they sign it before we finish negotiations.
They may have had a different date on there, but
Okay.
are you looking at the good
Look at
faith
the
form
execution date.
of the actual contract or the good faith form?
Yeah, it's November 29th, 2022.
On the good faith form. So that's the point of entry in interaction with our vendor relationship manager, not the execution date of the contract. So I just want to clarify that.
Okay, that makes sense. Because it seemed like a long time.
Any more question? If not, entertain motion for approval.
Move to approve.
Second.
All in favor, say aye.
Aye.
Any opposed? Motion passed. Thanks, Warren. Dr. Elliott, welcome.
Good morning.
Morning.
Good to see everyone this morning. I'm here to present actually two contracts and agreements here. The first one under consideration is our approval of our interlocal continuing education agreement between the University of North Texas Health Science Center and Tarrant County Hospital District. This provides our services around our continuing education and provides benefits across the board for the joint accreditation of multiple clinical activities that we do here. It is a 28-month term. We're doing it to align with our fiscal year now as we move forward. So there is a remainder for year one that is in our approved operational budget for FY23, along with the rest of those costs for those additional 2 years.
Any question for Dr. Elliott? If not, may I have motion for approval?
Move approval.
All in favor, say aye. Signify aye. Any opposed? Motion passed. Second one, please.
Thank you. The second one is for approval of the First Amendment to the Interlocal Library Services Agreement between University of North Texas Health Science Center and Tarrant County Hospital District. We are also aligning this over a 28-month term with an approved budget in year one for FY23, and for the cost you see there in year two and year three. As you know, library services are critical in terms of evidence-based and providing all of that care that we provide here and improving our patient outcomes. It's also a requirement for our ACGME requirement to have 24/7 medical library services available to our full team, and we're seeking approval.
May I have motion for approval?
Second.
Any question, discussion? If none, today, yes.
It's an interlocal. They are a federal and state agency, so there's no need for that. That's why it's an interlocal agreement there. Actually, no, even if we did that, it would be much higher cost. We've actually run the numbers, even looking at the accessibility and looking at that. And when we've run the numbers to see if we were able to do that without that, it's even excessively over $1 million.
What about a different government, say, for instance, joining with Parkland or joining with some other hospital district?
We've actually shown that we've actually done even better doing this with our local partners here.
Great.
Yeah. And we assess it, we do assess it annually and get those reports.
Great.
I will say the UNG library program is fabulous. It's one of the best at any hospital I've worked at. They are incredibly resourceful, available, and provide the clinicians with almost real-time evidence. So I just want to say it's a great program.
Yeah. And I will say the benefit is that we really count them as part of our team, and so they're very, very accessible to Dr. Miles' point, too. Yeah.
All in favor?
Aye.
Any opposed? Motion passed. Thank you.
Thank you.
Mr. Adam Lane.
So I have two contracts to bring forward to the board today. The first one is an agreement between Tarrant County and the hospital district for the South Campus, current South Campus, 2500 Circle Drive and 1400 Circle Drive. That is where South Campus is, the clinic and the call center, for $509,000 per year for 2 years for continuance of that lease. I won't say there's a multiplier, there is a lease rate, and they have increased the cost on the CAM charges because of the electricity.
What is multiplier? Trent?
What?
What was your question? The multiplier, what is that?
Yeah, I mean, if the lease had an automatic multiplier in it, that would increase it on an annual basis during the term of the contract.
Oh, I see, okay, escalation type?
There's none.
No CPI adjustment, anything?
I'm just always trying to get a better deal.
Entertain, we have motion for approval? Second. No discussion? All in favor? Signify by aye. Any opposed? Motion passed. Next one, sir.
Yes, so the next one is an agreement with Hutcherson Construction in Tarrant County Hospital District. The board may recall of providing $10 million for infrastructure projects. This is the last one of those tranches. This is for the emergency generator set. It has taken us 2 years to extricate the design for the life safety and critical branches so that we could finally get to this point. This is a CMAR contract, so the contractor was already approved earlier based on fee and general condition. This is the bid out of the subs for the final contract for the total scope of work. The scope of work is $3.1 million for 2 new generators and all the parallel and switchgear for the current hospital.
I'm going to pretend I know what you're talking about.
I'm sorry?
I'm going to pretend I know what you're talking about. Entertain motion for approval? Second. All in favor?
Aye.
Signify by aye. Any opposed? Motion passed. Thank you, sir.
Very much, sir.
We're relying on you. I will. Good morning, sir. Good morning.
Morning.
The floor is yours.
Thank you, sir. I'm bringing forward a request for Willow Ambulatory and Willow Ambulatory Inventory Management. Represents about $915,000. We own there are 4 modules that represent the Epic Pharmacy package. We already own core. We're coming forward with the 2. Willow Ambulatory provides the full functionality for outpatient, specialty, and retail. Those are handled by 2 systems, and just as a matter of fact, specialty is CPR Plus, and that's set to be sunsetted here, and this would replace that capability. The Willow Ambulatory Inventory Management System, a mouthful, is really the tracking of the inventory and managing the product itself. It's really designed to do 2 things. One, ensure that we're not wasting money by buying medications that aren't getting used, and second, to ensure that we don't run out of medications that the patients need. It's a complete inventory system in today's environment that is separate from the Guardian tool. That is a separate system and not interfaced as well. We're requesting this to move forward for both a tactical need. We're trying to push forward a comprehensive and integrated pharmacy management system, but there's also a strategic drive that's twofold. One, we're following an Epic first strategy, and because of that, what we're trying to do is improve the overall ecosystem performance. There's the value of the platform by having the data integration. As I said, the majority of all these systems that exist today are not integrated. There's a lot of swivel chair and manual operation, and that integrated data from from prescription to distribution function is in a single system, fully integrated at this point in time. And then the clinical integration, there's a value in the platform of integrated data. So we're providing the pharmacist with full clinical information that they don't have access at this point other than a swivel format. And we're providing the clinicians with full pharmaceutical information and integrated communications, which don't exist because the systems aren't integrated. So we're asking to move these two modules forward.
This is the most...
May I ask a question?
Yes, sir.
Thank you for presenting this, Will. First, it's the Willow ambulatory system, but it is an Epic product, or is it a third party?
No, this is all Epic.
Do you know why they call it Willow?
Yes, I do, because Epic likes to make fun of their products and name them. It happens to be named Willow because that's where aspirin originally came from, the willow tree.
Oh, I learned something today. Who knew? Thank you. Wow, and you knew that. That's impressive. Second, this should save operating costs. Do you think that this purchase will ultimately pay for itself?
Oh, I have no doubt, for several reasons, one of which is right now all the systems that we're leveraging are not integrated. This is a fully integrated system. It's also integrated within the clinical operations where we don't have that full integration. the system has the ability to be able to fully integrate back even to the supplier, which we're not using now. So there's a vast opportunity that we'll be able to leverage. Now, our friends at Maxor still provide an awful lot of value add. We're still going to have the integration to those value add tools so that they can manipulate the data and be able to provide the additional cost savings that won't be eliminated through this process.
You said Maxtor?
Maxor.
Maxor. That's another software.
Maxor is the organization that leverages, that is running our pharmacy system at this point in time. Yes, sir.
This is the most thorough explanation we ever received. Thank you so much.
Yeah, I really want to thank Will for coming in and really seeing Epic to be the driving system and integrating across the network. A lot of the work that we do. And so thank you, Will. This was a big lift and much needed.
I had a lot of questions during the review, but you explained thoroughly. I don't have any more questions on that one.
It's not as if it's fly by night. We're talking about a system that has 75% of the market share. So it's pretty well used.
May I have motion for approval?
Okay, move approval of the exception to bid and to the amendment.
And all in favor?
Aye.
Any opposed? Thank you very much.
Thank you, Will.
Do we have anything in closed session? If we don't, I think we are done with our meeting.
Okay.
And I entertain the motion for this adjourn the meeting.
Heck, okay.
Meeting's adjourned.
All right, we're going to call this HR Resources Committee meeting to order. There are no citizens wishing to address the committee. And then next thing, we'll go to the approval of the minutes. Do I have a motion to approve last week's minutes? Last month. Move approve. Second? Second. Any yay? Yay? Vote. Aye. Sorry. Any nay? All right, motion approves. At this particular time, we're going to go ahead and go into closed session for the remainder of our HR committee meeting, and we'll come out shortly. Thank you.
Okay, I just don't want to know one individual.
See you, Roger.
Bye, y'all.
Good luck with the construction.
Ms. Ogenberg, will you leave that one door open, I guess?
They're open.
Oh, you opened them already? Oh, okay.
It was nobody cares.
Thank you.
Bye, y'all. See you.
I didn't see anybody get up and open.
Second.
Approve, say aye.
Aye.
No nays. Motion passes. All right, thank y'all so much. Appreciate your time, and we are adjourned.
You're supposed to pound it.